السلام عليكم. The short clinical station day. First scenario, you are going to examine the abdomen of Mrs. Elizabeth Andrew. She's 47 years old. Please start examining her. Here you
Okay,
go.
hello.
Hi, hello.
I'm Dr. Abdul Karim. I'm I'm one of the candidates for exam today. May I confirm that you are Mrs. Elizabeth, 47 years old?
Yes, that's me, doctor.
Yeah, I would like to examine your tummy. Is that okay with you?
Yes, please.
So, if you feel any pain or discomfort, please let me know. Is that okay?
Okay, I will.
Okay, so I'm going to wash my hands and just please expose your tummy for me.
Okay, put me exposed.
Okay. So start by examination by examining the hand of the patients.
Hmm.
Please show me your hands, please. If there's any
Okay,
clubbing,
no clubbing in the hand.
any leukonychia,
No,
coloonychia.
no.
Okay, so could you please turn your post hand for me?
Hmm.
Just show me your palms.
Okay.
Okay. Any palmar erythema, pituitary
No,
contraction.
no.
Okay. So could you cook your fingers, please? I'm going to
Okay,
check if there's any flapping tremor,
okay, no flapping tremor.
any fine tremor.
No,
Okay, so I'm going to check the both arms if there's any fistula or
no
any
fist,
scar.
no fistula, no scar.
Okay. So the general look of the patients in the face, if there's any thalassemic or any facial deformities, bone
No,
deformities.
no,
Okay. So I'm going to examine the eyes. Is any pallor, any jaundice?
no pallor, no jaundice.
Okay. So could you please open your mouth for me?
Okay, I've opened my mouth.
Okay. So any yes any sign of anemia in this patient?
No,
Okay. Where is the image? Oh, okay. Okay. So there is gingival hyperplasia or hypertrophy in this
okay.
patient. Okay. Okay. So after that, I'm going to check for the JVB. Could you please
Mm-hmm.
turn your neck for me, your head?
Okay.
Yeah. Okay. If there is any
No
severe
JVP, JVP
JVB,
no raised.
I will confirm with hepatojugular reflex. Do you have any pain in your stomach?
No, no doctor.
Okay, so I'm going just to look for the axillary hair and yes, if there's any spider nearby or
No,
in the face, if there's any wasting of temporalis muscle, budget enlargement.
no doctor.
Okay, so just I'm going to inspect the abdomen. If there's any scar, any distended abdomen.
Okay. I think that okay, you will expect an image, okay, of the
Okay,
abdomen.
okay, where is the image? Okay. Okay, so okay, okay. Okay. Okay, so after that, I'm going for the lower limb of the patient, lower leg, if there is any beating edema.
No pedidema.
Okay, could you please give me a cuff to take the breath in and out if there's any superficial masses?
No.
Okay, I'm going to warm my hands. I'm start palpation, superficial palpation first. Do you have any pain? Just I'm going, I will confirm the patient lying flat.
Mm.
I will sit at the level of the patient.
Okay.
There's any superficial masses?
No.
Okay. So I'm going to start deep palpations. I will palpate regarding the liver. If there's any liver enlargement in this patient.
No. No. No liver enlargement.
Okay. So I'm going also yes regarding the spleen. If there's any spleen palpable.
No.
Okay. The kidney by manual palpable or not?
No.
Okay, I will check for shifting tenderness in this patient. If there's any positive for
No.
ascites.
No ascites.
Okay, so also I'm going to check the skin if there's any bruises, any
No.
ecchymosis.
No bruises. No ecchymosis.
Okay, so any thin skin in this patient?
No.
Okay. Yeah, I will auscultate the abdomen if there's any for the bowel sound and the venous hum
Mm.
and
But we're
renal.
normal bowel
Okay.
sound, no venous hum.
Could you please sit sit for me, please?
Okay.
Yes. I'm going to check for the bed of the lung if there's any bipedic crepitation.
No.
Okay. Do you have any pain in your back?
No.
I'm going to check for sacral edema.
No sacral edema.
I'm going to examine the lymph node for this patient.
1 minute left.
No lymph node enlargements.
Okay. Okay. Thank you. Now you can take your rest, and I will cover the patients.
Okay, how to examine the lymph node before finishing the steps? Give
Yeah.
us the
Just
instruction.
I will
Yes.
start. Yeah. Okay. So, Mrs. Ali, the best. I'm going to examine you from your from the back. From your back of your from the behind. I will
Okay.
start to check for the thumbmental, thumb-mandibular, yeah, anterior cervical and posterior cervical. Okay, anterior auricular and posterior auricular and supraclavicular lymph node in this patient. It's the most important. And I will offer the axillary and other inguinal lymph node if there is any significance of finding.
Okay,
Okay.
doctor.
Okay, examine your
Okay.
question.
All right. Well, okay, can you present your patient, please? Present your
Yeah,
findings.
I have examined Miss Eliza, 47 years old. Yes, on examination, she has got, yeah, she has got Mercedes-Benz scar and in her tummy, okay, in her abdomen, and also she got gingival hypertrophy. And apart from that, I could not appreciate any finding in our examination. There is no organomegaly in this patient, no sign or stigmata of chronic liver disease in the patient, and also I could not appreciate any sign of bruises or thin skin in these patients. I believe this patient, she has, yes, she has Mercedes-Benz car with the, yes, below it there is a small scar, I think, with a gingival hypertrophy for differential diagnosis. In view of gingival hypertrophy, I believe this patient, she has liver transplant.
Okay. Okay, so what are the differentials?
Yes, other differential for this liver transplant, it could be for this scar. Yes, it could be pancreatic surgery, and also it could be gastric surgery, and also it could be hepatectomy also. Yeah.
Good. Okay, so could you tell me, this patient says she has had liver transplant. What are the possible reasons that you think this lady would have had a transplant?
Yeah, the reason behind the liver transplant for this patient, you mean?
Yes, the possible indication for
Yeah,
transplant
okay.
in this patient.
Yeah, it could be due to fulminant liver failure. It could be due to liver cirrhosis. It could be due to refractory ascites, but again, that I didn't find. And also, it could be due to paracetamol overdose.
Okay. All right. So could you tell me what are the possible, this patient has gingival hyperplasia. So tell me, what are the things that could cause gingival hyperplasia?
What are?
Causes of gingival hyperplasia. What do you think might be causing gingival hyperplasia in this
Okay.
patient, and what are the other
Yeah.
causes of gingival hyperplasia?
Yeah, the cause of gingival or gum hyperplasia in these patients is most likely it is one of the side effects of immunosuppressant medications like tacrolimus, cyclosporine.
Other possible causes of gingival hyperplasia that you're aware of?
Other causes apart from medications, you mean? Yeah, it could be myeloproliferative disease like AML, and also it could be due to other drugs like buntoin and calcium channel blockers. Okay. Yes, it could be due to trauma, infections.
Okay. So what are the possible complication of liver transplantation that you're aware of?
I didn't hear you.
Complication of liver transplants that you are aware of.
Okay. Yeah, the complications of liver transplant, yes, itself, yes, and complications of the medications, immunosuppressive medications. Okay, like recurrent infections, complication of the liver itself, failure or rejections, and infection also, and sometimes thrombosis, and also infections of the and complications of immunosuppressant medications like cancer, recurrent infections because of immunosuppressant, and also it could be like lymphoma, other, and also cyclosporine toxicity like hyperkalemia, hypertension, and other side effects.
Okay, thank you. So what are the other possible scars that you can see in a patient with liver transplants?
Yes, other scar, yeah, reverse J scar also, and also roof top scar. Okay. Yeah, and
Okay.
yeah.
Okay, thank you. Well done.
Thank you.
Okay, thank you, Dr. Ayula, for the case, and thank you, Dr. Sarah, for the performance. Good performance. Let's hear the comment from Dr. Ayula, then we'll move to the next scenario.
Well done, Dr. Sarah. It was a good presentation, good examination skills. Hopefully, we were able to translate this to the patient side, but it was a good steps in examination. You checked virtually everything that was needed to be checked. You even went as far as checking for any skin changes. I'm pretty sure you are looking for any form of skin cancer in this patient that had previous transplant. It was a very good one. Okay. There's just one or two things during the examinations. Position. Let's start from the position. You expose the patient well. You take permission. You did every other of those. But when you want to examine before you start examining the abdominal examination, what as in proper abdominal examination, would you want to put this patient, Dr. Sarah? You want to put this patient in 45-degree heads up, right?
Yes.
And when you want to go ahead to continue with the examination, I mean, to the abdominal proper examination, you put the patient flat. I knew you said you wanted to put the patient flat when you were going for the abdominal examination, but it's also good to say that the patient will be 45-degree head up when you are doing all of the examination, especially when you're checking the JVP. Okay, just so it become a part of us when we get to the patient side proper when you're doing that. Okay, that's just the thing I can say in the examination wise. Examination was good. So let's talk with the presentation, okay, of this case. Presentation was also good. You got the diagnosis right. It's a Mercedes-Benz car, like the patient has done liver transplants, and other differentials would have included previous history of gastrectomy, like you mentioned, previous history of liver resection, even esophagerectomy, even Whipple's procedure, they can use this kind of scar for it, like you've said. All those were good. Then when you were making your diagnosis, you said the patient that had liver transplant. When making the diagnosis of any form of transplant, it's always good to say if this is functioning or not functioning, okay? Or if there's any evidence of failure, which in this patient there is none. So it would have been better, it would have been good, I mean, to say that if you say that this patient has possibly deficient of liver transplant with possibly a functioning liver transplant and complications of treatment, like you said, that patient has liver hypertrophy. So it's also good to put it down there to show that yes, you are thinking, though you discuss that, but it's good to put it in a say strength things when saying your differential. So it's always good to say if the transplant is functioning well or is not functioning, and if there's any complication that you've picked, which in this patient you've picked a complication of long-term immunosuppression in her. Okay, that was one thing I noted down. The other thing I noted down is the gingival hypertrophy. Where you said that, excuse me, that tacrolimus is the culprit. No, it is cyclosporine. I know it's a slip of tongue. Cyclosporine is the culprit for gingival hypertrophy. Okay, and those things that tacrolimus could cause could include, hyperglycemia, metabolic syndrome, and things like that. Are those that are associated with tacrolimus. So for the what else did I note down here? Okay, causes of gingival hypertrophy. You did quite well with that as well. You mentioned a couple of things. Other thing that you should have mentioned in this patient could include recovery. That's vitamin D, vitamin C deficiency. It could be due to pregnancy. It could also be familiar. I think those are the ones that you did not mention, just so it can be. I know it's because of the exams outset. There are things that we are quite familiar with. Okay, so another thing I noted down again in this, I think those are the basic. Then the complications of transplant. As you went through it extensively, but I think it would be easier for us if we can group it into the complication of any transplant. Just group it into the complication of the graft itself, complication of the surgery, and complication of treatment, of immunosuppression treatment. For the complication of the graft, you could say acute, hyperacute, and chronic complication. Even chronic rejection of the graft can go for that. Complication of the treatment can be acute, such as pain. They can have pain. They can have what else? Bleeding, hematoma, physical thing, and anesthetic problem from the surgery, and complication of treatment, complication of instead of complication of the grafts. Okay, those skin increased predisposition to cancer, such as skin cancer, can also come under that. The complication of treatment, then you go into tacrolimus, which can give hyperglycemia, metabolic syndrome, cyclosporine, which can give hyperkalemia, gum hypertrophy, non-steroid use can give to Cushing syndrome. Also, mycophenolate effects, which can give diarrhea. So those are the things that show that it will be well grouped, and it would, I think when you say it like that, it will run smoother. But obviously, every of these things. So they are quite good. So yeah, I think basically that's my contribution. Well done, Dr. Sarah. Well done.
Yeah, thank you, Dr. Ayula. The comment, I will reserve the comment for both discussion of the second scenario. Dr. Sarah, please. You post the scenario for Dr. Ayula. The discussion will be raised again after the second scenario. Everyone will know why, but let Dr. Ayula present and finish the discussion. Then I will add some questions, and we will sum and recap all the questions in the next scenario. Okay? So she will go to examine Mrs. or Mr. Dr. Sarah. The patient will.
Yes. Mrs. Fatma. Yes, Mrs.
Okay.
Fatma. Yeah, 20
How
years
old?
old.
20 years. Okay. Dr. Ayula.
Please examine her abdomen. Yeah.
Yes, okay. So you are going to examine Mrs. Fatma or Miss Fatma, 20 years old. Please examine her abdomen.
Okay.
Okay.
Just a second, please. I'm having issues with my connection. I just want to.
Yeah, it's good.
Yeah, all right. I think it's good now. Yeah. All right.
Yeah,
so,
here you go.
Hello. Mrs. What? Sorry, can I get the name again? I can't see it.
Fatima.
How old? 27?
Just 1 minute.
20.
I will
20.
send the picture. Yeah.
Okay, all right.
Yeah, I will send it on time, Doctor. I will send it on time. When she examined the abdomen, I will send the picture, okay? Just focus with her questions. I have the photo.
Okay, all right. Hello. Yeah. Hello.
Yes, hello.
Yeah, my name is Dr. Yola. I'm one of the doctors here. Okay, can I confirm you are Fatima, 27 years old?
Yes, doctor.
Right, thank you for allowing me to examine you today. So I'll be examining your abdomen, your legs, your face, okay, and your hand as well, okay? Is that all right with you?
Yes.
So I want to, I will sterilize my hand, okay? So all right, I'll put my patient in front of the head up, and then are you able to expose your tummy for me?
Yes, yes,
So,
doctor.
so I will look around the patient's bed and then I'll go to the foot of the bed. Can you breathe and out for me? And are you
Yes.
able to
Okay.
give me a big cough? Can you cough out for me, please? Any hernia? Any
No.
congestion on your okay, any swelling? All right, okay. So thank you. You can cover your tummy for now. We'll come back to that, okay? So can I look at your hand, please?
Yeah,
Okay.
negative.
Any conychia, okay? Any deformity on the hand, okay? So I look at the palm again. Any palmar erythema in the hand, anything? All right. So
No.
all right. So thank you. So at this point, I want to know what the patient's blood pressure is. All right. So I go to the hand again. I look at any form of fistula. Is there any fistula in the hand? Any scar? Any tattoo?
No.
Any tattoo in the hand? And tattoo in the
No.
body? Any scar? All right. Thank
No.
you. So I want to. Are you able to face the other side for me? Turn your head to the other side, Miss Fatima. Okay. All right. Is the JVP elevated?
They're not elevated.
Okay. Have you got any pain in your tummy?
No.
I want to check hepatojugular reflex. Okay. All right.
Negative.
Thank you. So can you use your hands to lower your eyelids, your lower eyelids for me? Any anemia, any pallor?
Yes, there is blood.
Okay. All right. Thank you. Okay. Can you raise the upper eyelid for me and look down? Any jaundice?
Yes, she jaundice also.
It's jaundice as well. All right. Thank you. So can you sit up for me? Can you open your mouth for me? Okay. Can you open your mouth? I flash my light inside. Any cyanosis? Can you bring out your tongue? Can you raise it up? Show me your teeth. Any findings? Okay.
Negative.
Negative. All right. Thank you. So can you able to sit up for me, Fatima? At this point, I want to check your glands. Okay. It might be a little bit discomforting, but I don't expect to have any pain. Because if you do have pain, do let me know. Okay. So I'll start from the subomentum. So I'll go to the I'll go to the postauricular. I'll go to the occipital. Can you shrug your shoulders for me, please? Supraclavicular lymph nodes. I'm examining any of those. Any lymph node enlargement?
No, negative.
Okay. Have you got any pain in your back?
No, no, doctor.
Okay. Any sacral edema?
No.
Okay. So I want to listen to the back of the back of your chest now. So can you breathe and out for me? Any pleural effusion? Any calculus?
No, negative.
All right, all right. So can you lie down for some? Are you all right to lie down flat, Fatima? So I want to put the bed flat. Okay.
Yes.
And again, to open your tummy for me, and put your hand by your side waist. So I'm looking out for any scars. Is there any scars in the tummy?
No scar.
No scars. Okay. All right. So before we go ahead, I just want to check your chest again. Have you got any spider nerve? Your axilla? Any loss of axillary here?
No.
No. Okay. All right. So have you got any pain in your tummy, Fatima?
No, doctor.
All right. So I sit down by the patient's side. Okay. So I'm just gonna press gently on your tummy. So you let me know if you have any pain. While I'm looking at the patient's face, checking in the ninth quadrant, any tenderness, and then I go deeply to check for any mass. Is there any tenderness? Then I get deeply to check.
Not.
No tenderness. I go deeply to check for
No
any.
tenderness.
No
There
tenderness.
is mass. Yes,
There's
there is mass.
okay. Where is this mass?
Yes, in the right hypochondrial area.
In the right secondary area. Okay. I cannot get above it, right? Is it the liver?
Yes.
Okay. Is it smooth? Is it cracky? Is it smooth? Is it hard?
Yes,
Is it
smooth.
firm? Okay, and smooth.
Firm.
Okay. Firm. Okay. Is it pulsating?
Yes.
Is pulsating?
What?
Is it pulsating? Any
I
pulsatile
didn't
liver?
get you.
Okay, it's not pulsating.
No,
All right.
negative.
So I want to check for the spleen as well. I'm checking for the spleen. Is the spleen enlarged?
There is a mass below the
There is
left hypochondrial. Yeah.
hypochondria. All right. Any splenic notch?
Yes, the
Yes,
medial part.
the splenic notch. Okay. All right. Thank you. So at this point, I want to check for. Can you lie down for me? But I want to check for the kidney. Are the kidney ballotable?
Negative.
Negative. Okay. So I want to tap on your abdomen for now. So bear with me. So I'm checking for ascites. Any ascites?
Negative.
Negative ascites. Okay. All right. Thank you. So I want to listen to your bowel. Okay. So I put my stethoscope. And what does the bowel sound like?
Mm-hmm.
Is the bowel sound normal?
Yes.
Okay. So any hepatic breath?
Any what?
Hepatic growth. Is there any sign of the liver?
No.
No, okay, it's not possible. Okay, all right. Thank you, Miss Mrs. You cannot cover yourself, Mrs. Fatima. We are done with the examination in your abdomen, but do you have any pain in your legs?
No, doctor.
I want to check for pedal edema in the legs as well.
Negative.
Negative. Okay. Thank you for allowing me to examine you today, so you can cover yourself, Fatima. We are done with the examination.
Yes. Well done, Dr. Ayula. It's 6 minutes now. Now the
Okay.
examiner questions.
Okay, please present your case for me.
Okay. I have just examined this abdomen examination for this young lady. On peripheral examination, he appears to be pale and also have jaundice. No evidence. Also have jaundice, and there's no evidence of fluid overload in her. On further examination of the abdomen, there's no lymph node enlargement. Examination of the abdomen, there's no scar, but there's hepatosplenomegaly. No ascites was demonstrable. To further ascites was demonstrable. I would have loved to further assess for digital rectal examination, urine analysis in this patient, and as well as checking for the inea orifices. Putting all of this together, I'm suspecting that this patient might have chronic hemolysis in her. Possibly, possibility could include thalassemia, sickle cell disease in her. It could also be due to some lymphoproliferative disease, but we expect that patient should have a lymph node enlargement. Other possibilities could include infiltrative diseases like amyloidosis, Gaucher disease as well.
What is the differential diagnosis of chronic hemolytic anemia?
Differential diagnosis of chronic anemia includes thalassemia, sickle cell disease.
Which against sickle cell disease in this patient?
You say what?
Which against sickle cell disease in this patient?
Which?
Against sickle cell.
What against sickle cell?
Okay, what's against sickle cell disease in this patient? Well, I would have expected if you look at it, I would have expected some physical signs in this patient, like frontal buzzing.
No, what against to be sickle cell? What in the manifestation or the symptoms? In the signs against sickle cell?
That is against sickle cell.
Yeah, what against sickle cell?
Oh, yeah. I'm not quite sure.
Okay, what do you think the finding in this patient? If you have, you will not say this is sickle cell. If you will have this thing in the manifestation or in the examination, you will say this is not sickle cell. You got the question? Okay, forget about it. Continue, Dr. Sarah.
Yeah, no problem. Yeah, you can continue. What other differential for chronic hemolytic anemia?
Other differential will include artificial anemia will include autoimmune anemia. As well, could autoimmune anemia will also cause this. Then those are the things I can remember for now.
Okay. So what is the complications? Yes. Imagine this patient, she has thalassemia. So what is the complication of thalassemia?
Complication of thalassemia could include iron overload. Could also include they could also include heart failure, because with a complication of thalassemia. Other possibility could include liver disease as well. Then affectation of the
Why the thalassemia patient got chronic liver disease? Yeah.
Is that what?
Why thalassemia patient yes got chronic liver disease? You mentioned chronic liver disease. What is the reason behind this?
Recurrent hemolysis can lead to recurrent hemolysis can cause blockage of the hepatic vessels, okay, and this can cause some form of can lead to some form of cirrhosis in them.
Any reason other than this?
Any reason?
Any cause? Other cause?
No, I'm not quite sure. Infiltration as well. Can also have infiltration as well. I'm not quite sure.
Okay, no worries. Okay, so yes, what is your workup for this patient?
My workup for this patient will include making a diagnosis of thalassemia, which will include doing an hemoglobin electrophoresis, looking out for HbA2, which we are expected to be increased in patients with possibly beta thalassemia, especially. Then also I also want to do a full blood count, looking out for hemoglobin level. I also do a liver function test to include the bilirubin level, which I expected to have elevated unconjugated hyperbilirubinemia. I'll also check for lactic acidosis and serum aptaglobulin as well. Other things I want to do will include doing a glucose test glucose tests. Also check for the albumin and clotting profile of this patient. I also want to do a mineral bone assessment for him, looking out for osteoporosis in patients with thalassemia.
Okay, doctor, what is a plan of management or workup for plan of management for this patient?
For the management of this patient, is multidisciplinary, and it will include the hematologist, its psychologist, okay? And this also includes the genetic team. Patient education and counseling is quite important in this patient. Is a chronic disease. So management will include chronic transfusion for the anemia. Okay, you also want to give the chelate for the ion chelation as well. And if there's any form of
like what, doctor? Like what? Ion chelating?
Ion chelation. What do you do for the ion overload?
Yes, give me example for medications.
Indications.
Medications. Ion chelating
or
agent,
ion
like what?
chelating agent. I can't remember anyone for now.
Okay.
Okay.
No worries.
All right. So you don't want to do. You also want to manage them for the complication of thalassemia, such as bisphosphonates. If they have osteoporosis, if they have diabetes, also you also want to manage that that as well.
Okay. So do you know regarding the deformity that happening in thalassemia patient?
They could, is it a skeletal deformity?
Bone deformity. Yeah.
Bone deformity. Okay. They can have They can have frontal bulging.
Yeah.
They can have.
Yeah.
They can have the maxilla frontal bursting. They can also have gonadopathy, maxilla overgrowth as well, can also happen in them. They can also have scoliosis as well.
Okay. So what is what is the surgery that it might be done for this patient, in thalassemia patient, I mean?
The same patient could have chronic. They could have they have a high risk of stone formation. High risk of stone formation. So they could have cholecystectomy can be done for them.
Okay.
And
Anything
also
else?
you could also do splenectomy as well.
Okay. So what is the indication of splenectomy in this patient? In thalassemia patient, I mean.
Okay, indication for splenectomy indication will include chronic will include okay, will include anemia. No, I don't want to go. No.
Okay. Okay, thank you,
I
Doctor.
mean, severe anemia and like yeah. And
not anemia.
severe
Indications
anemia,
like
splenomegaly.
not anemia. Indication for surgery, splenectomy.
Okay.
Hypersplenism, massive splenomegaly,
Okay.
or rupture splenia. Increased demand
sure,
of blood transfusions, more than 50%. Okay.
Okay.
Okay, thank you.
Okay, thank you, Dr. Yola. Well done. Let's hear the comment from Dr. Sarah, then I will comment.
Yeah, she did well. I wait you to request for the face of the patients just to confirm the thalassemia in this patient. Because when you are examining the eye, she find her anemic and jaundice also. Okay. Also, I have a comment. It might be this your way in the examination, but just in the presentation for this patient. Yeah, you didn't present for me like I find mass below the left, like below the right hypochondrial, which is kida, which is 6 centimeter. You didn't ask me regarding the liver span. You didn't check. Okay, this is most important, and also in the spleen, how many centimeters enlarged below the left hypochondrial. Okay. So yeah, this in the presentations. Okay, regarding the differential diagnosis of chronic hemolytic anemia, yes, thalassemia, because your patient thalassemia phase, and also you can put sickle cell anemia. When I ask you what against, I mean splenomegaly in these patients. Usually, sickle cell anemia is belong to me before as young, more yeah, okay. If you find splenomegaly in sickle cell anemia, you think like sickle thalassemia. Yeah, is associated with thalassemia. Okay. Also G6PD deficiency, one of the differential, but again, is that this patient she's female and G6PD deficiency is X-linked recessive. So usually we find G6PD in the male patient. Okay. Other cause of chronic hemolytic anemia like autoimmune, yeah, it could be like you can say congenital and acquired causes. Acquired like autoimmune. Okay. Yes, just the differential diagnosis of patients hepatosplenomegaly with pallor. Okay. And in these patients, you can find chronic hemolytic anemia, number one, and myeloproliferative disease, and also lymphoproliferative disease, but against that, no lymph nodes. Okay, and chronic liver disease also. Against that, no stigmata of chronic liver disease in the patients. Okay. Regarding the workup for thalassemia patient or like patients, the most important specific investigations, just full blood count with blood film is the most important, and also hereditary hemoglobin electrophoresis. Okay. Abdomen ultrasound just to confirm our diagnosis, our finding. I mean hepatosplenomegaly. Okay. Hemolytic screen for this patient is the most important. Hematinic, okay. Investigation for complications like this. The complication of thalassemia patients, complication of disease itself, like anemia, patient she can develop anemic heart failure also, and complications of bone deformity, okay. Like you mentioned, frontal boothing and flat nasal bridge and prominent zygomatic bone, and also sometimes malfluidities. Yes, and other complications, secondary systemic complication, which is the secondary hemochromatosis. Okay. Also, a complication of recurrent blood transfusions like viral infection, hepatitis. Should screen for that, and also should investigate for the complication like hemochromatosis also. Okay, regarding the yes. Regarding the workup, regarding the management for this patient, non-pharmacological and education, MDT, and also, the pharmacological, like ion chelating agent, like dysphoroctamine, dysphoro, dysphoro, dys, dysphoroxox, okay, and ما قادرة أنطقه طبعا. صار لي ماسي. Okay. Other, Dr. Bathim, you can correct me. Okay. Other, yeah. Yeah, okay. So, Dr. Basim, you can comment.
Yeah,
now.
you mean there is IV form and oral form, dysferoxamine
Yeah,
as
dysferoxamine and
IV injection.
bisoprolol.
Okay, this was yeah.
Yeah, and dysbrifone for oral form.
Yeah,
Debrifone, I think.
exactly.
Debrifone. I'm not sure also about the spelling.
At least
But you can say, as an example, we have
bisoprolol. Yeah.
injection form and oral form. This is for the iron chelating. Don't forget to add for the complication the hemolysis. Patient might present
Yes.
with hemolytic crisis, and as you know, the hemolytic crisis patient might present with severe anemia, and you mentioned already the anemic heart failure. The jaundice, the gallbladder stone, one of the complications. That's why possibly those patients they had cholecystectomy. Okay, the spleen as splenomegaly manifestation, and the patient might be presented as a complication of either hypersplenism. This is the indication of splenectomy. So hypersplenism or massive splenomegaly. These are the indication for splenectomy. That's why they have some of them they have splenectomy. Okay. Regarding a complication, I like if you, as Dr. Ayula, for the first scenario, divide the categories of the complication, either related to the medication or related to the surgery or related to anesthesia or related to the scar or related to the graft. Here also you can relate to some categories. And the top of them, the disease itself. So the recurrence of hemolysis, the manifestation, or related to the blood transfusion. So you can say secondary hemochromatosis, or you can say related to the medication patient is taking and the blood transfusion itself. So the infection risk, because as you know, not all blood will be clean. Patient previously, particularly, they have transmitted some of the HIV or hepatitis, and occasionally they might have hepatitis on top of sickle cell or sorry thalassemia. So please don't give the examples of complication. Try to put them as categories, okay, related to the blood transfusion, related to the hemolysis, related to the anemia itself. So the patient might present with severe anemia, anemic heart failure. So you can tell as a cause or as a presentation or as a complication. Better to systemize your answer. Don't give the complication without category. It's better to be mentioned as systematic one. Okay. The second or the other point to be discussed, the scars. Here, yes, you might have either cholecystectomy, lab chole scar, or a splenectomy scar, and possibly if the patient have chronic liver disease with liver failure, sometimes I don't think it's common, but maybe you can mention definite treatment as liver transplant. Okay, for the failure, I mean.
In this patient, yeah,
Continue.
definitive surgery, it could be bone marrow stem cell transplant.
Yeah, stem cell transplant, yes.
Not
And
liver.
I saw patient with thalassemia with the stem cell transplant, and again it failed. So it's not the definite. Sometimes the recurrence of the disease or even the infection related to the immunosuppressant medication. So not all patients will be recovered. But you can mention definite treatment here will be stem cell transplant, particularly the young patient. And don't forget the hemochromatosis or the iron deposition as a complication. You can put a lot of complication due to iron deposition. So you can talk about pituitary. So the patient might have hypopituitarism due to iron deposition in the heart as well, in the liver as our case. So the patient will present also with hepatomegaly, or in the males in the gonads, they might have also impotence, right? These are the complications related to the iron deposition or recurrent transfusion and particularly iron
Hemochromatosis.
deposition. Yeah, hemochromatosis. Yes, exactly. Okay, this is regarding the second case, but I really like when Dr. Ayula have the diagnosis without the picture. Although the picture is put diagnosis, but she get the diagnosis without the picture. I'm waiting for her to ask for the photo. Then she recognized the diagnosis without the photo. But if she look to the photo, of course, she will have the diagnosis definitely from the first look. This is a case of frontal bossing, as you see in the chat box, the picture of the patient, frontal bossing, and it's clear, straightforward with the pallor along with the jaundice. You can say this is a thalassemia or chronic hemolytic anemia patient. Particularly, the thalassemia is as common presentation. The other differentials, of course, you can say sickle cell. However, against that, there is no splenomegaly, or there is splenomegaly in this case, and in the thalassemia, possibly they have splenectomy, autosplenectomy. So it's not common to have splenomegaly. The third differential, hereditary spherocytosis. I don't know, Dr. Sarah didn't mention. It's common, by the way, in Europe. So you can say as a differential hereditary spherocytosis, which is autosomal dominant, and glucose 6 phosphate dehydrogenase, as also in males, not common to be in females. Females always as a carrier, but it might be presented or the patient might be a diseased one if he is male. Okay. This is regarding the second case. The investigation already mentioned, starting from CBC for anemia, the hemoglobin electrophoresis for the type of hemoglobin, up to the investigation or image. You can do ultrasound. Even some cases, they might need to do bone marrow aspiration or even liver biopsy to confirm hemochromatosis in the liver, I mean. This is as invasive testing. Genetic testing also can be added to the investigation. Last investigation of the complication. Yeah, we didn't mention the pancreatic deposition of iron, so the patient might have diabetes. Hemochromatosis, I mean complication. So diabetes investigation, you might have the patient with the diabetes, or you can investigate for diabetes hemoglobin A1C. Yes, also you can add pseudo gout as a complication of hemochromatosis again, and thalassemia. So it's a wide differential, a wide complication, a wide investigation. Thalassemia is not localized disease, it's systemic disease. It might affect either from the disease itself or the related to the blood transfusion. Frequently, they are receiving blood maybe 3 monthly. So the frequent transfusion might also have a lot of complication. Okay. Any question regarding this case? Anyone want to add any comments? Feel free. Okay. If no comment about the second case, we will talk shortly about the first case.
Dr. Bazim, sorry.
Yes, yeah, Dr. Henry, go ahead.
The question, the scenario, was it hepatomegaly the patient had or splenomegaly?
Yes.
I was not
Why?
quite sure. Which one? Was it hepatomegaly the patient had
Yeah.
or splenomegaly?
No, both. The patient
He
is
had both
having,
of them. Okay, both.
yes,
Okay.
yeah,
Okay.
yeah, they
Thank you.
might have both of them. Okay.
Okay. All right. Thank you.
Possibly the thalassemia patient, they have either, not either, both of them, either or hepatosplenomegaly or splenomegaly itself, unless there is end stage or chronic liver disease. So you might have cirrhotic liver as infiltrative disease, as hemochromatosis infiltration. So you might have chronic liver disease manifestation in the form of shrunken liver as cirrhotic, then splenomegaly, and the other manifestation of chronic liver disease like ascites, jaundice, gynecomastia, and loss of hair, ecchymosis. Why it happened? Because of hemochromatosis. As you know, one of the causes for chronic liver disease, you can say infiltrative, right? Infiltrative amyloidosis, hemochromatosis, one of them, right? So it's possibly with the long-term disease manifestation, they might be as cirrhotic liver with manifestation of chronic liver disease. You got it, Dr. Henry?
Yes.
Yeah. So early stage, they might have hepatosplenomegaly as a thalassemia and recurrent hemolysis. And the liver, of course, as you know, the liver is the store of the blood. So they might have hepatosplenomegaly. But with the long term, with the long or recurrent blood transfusion, the liver will be shrunken due to hemochromatosis as infiltrative. Okay, the management already we talk about, so you have to talk about the hemolytic crisis. If the patient is already in hemolytic or acute presentation of hemolysis, you have to mention ABCD approach, admitting the patient, requesting blood group. Those patients might need urgent blood transfusion, especially if they have anemic heart failure manifestation. Some patient, if they have, but this is not the thalassemia. I talk about sickle cell uh, exchange transfusion. So, in order to have clear idea about the manifestation, you have to do hemoglobin electrophoresis, and according to the results of hemoglobin S, you might do the exchange transfusion. But in the thalassemia, possibly they have anemia different than the sickle cell patient. So you might transfuse the patient with the blood to correct the anemia. Plus multidisciplinary team approach, then you can talk about hepatologist, the internal medicine and specialized nurse, even cardiologists. Some patient will have manifestation of hemochromatosis in the heart failure patient, so you can also involve for diuretics after blood transfusion. So it's a wide, as I said, wide topic, either manifestation or management or investigation. And let's talk about the first case. If no question for the second. Any question before moving to the first
No,
scenario?
no, doctor.
Okay. Supposed to have two cases about Mercedes-Benz. I think Dr. Sarah sent me the same, but another patient, of course, about Mercedes-Benz car. That's why I didn't comment about Dr. Dr. Sarah
Yeah.
performance earlier, but Dr. Sarah changed the case to thalassemia. But occasionally, both of them, Dr. Sarah and Dr. Ayula, send me Mercedes-Benz car. That's why I didn't comment about the first topic, which is transplant, liver transplant. Now we will talk about it briefly. I will try to be shortly in the discussion. How to present, already presented well by Dr. Sarah. You have to talk about the peripheral manifestation and the central. This is what I prefer to talk about. So peripheral manifestation as in the hands and the or the arm if there is some fistula or whatever. Then the central. So you are talking about jaundice, the scars, the abdomen examination, the tender, ascites or percussion or auscultation, whatever. The case was straightforward. After you see the scar, you are lucky to see a scar in your case. Why? Because you will narrow your differential. You will not think about a lot of disease. You have to think about what the scar for. If you got the scar, the indication of the scar, the question will be related, what is the scar for, particularly transplant. So one of the scars for liver transplant, the one we saw already, Mercedes-Benz scar, or rooftop, as mentioned, or J-shaped scar. The indication of transplant, always look at the patient age. Before mentioning the possible cause, think about the age of the patient. In young patient, you have to think about acute causes because no one will present with the chronic form of the liver disease in the young age. Instead, those patients in young age with suicidal attempt, for example, they are taking paracetamol for suicidal or by mistake, whatever the reason, then their liver will be damaged by the paracetamol. So the most common cause of liver transplant in young group of people, you have to say post paracetamol toxicity in the top of them. After that, you can say trauma or anything else, cancer, but don't tell or don't say about the indication or liver transplant in young, for example, chronic liver disease patient. It's very rare to have chronic liver disease in young age. That's why the acute form you have to talk about either medication overuse or intoxication like paracetamol, or trauma or malignancy. However, it's not common as well. Let's talk about the chronic or the elderly the group. We'll talk about chronic liver disease, right? The chronic liver disease or cirrhotic liver, whatever the reason. So you can again categorize your answer either infection or infiltration or autoimmune or malignancy, right? Medication can be, but it's not common as in the young group. What are the infection causes? Hepatitis C or B, of course, with the progression of the disease. Then the infiltration or the infiltrative cause, as mentioned earlier, the amyloidosis or hemochromatosis. Then the sarcoidosis as well. Then the infiltrative autoimmune. You can mention any autoimmune hepatitis, primary cholangitis, or primary sclerosing cholangitis. Those are the causes of liver disease. Then, you can add to the infection, particularly in Egypt and Sudan, bilharziosis. Okay, because it's not anymore nowadays, but it can be in the early or elderly patient. So you can add them to the infection. So hepatitis B, hepatitis C, and the bilharziosis. By the way, as endemic, the question in Europe, what are the most common infection in Europe will be hepatitis B, right? While in Egypt and Africa, hepatitis C. They are asking this question. So what type of infection you think? Okay, next, the cancers, as we mentioned, the hepatocellular carcinoma or or cholangiocarcinoma. These are the indication for transplant. The complication, as mentioned earlier by Dr. Ayola, so you have to think about the complication of the surgery itself, anesthesia, the graft itself, and the medication or immunosuppressant. Okay, for the graft itself, think about three common, and they like to hear them. The infection, particularly cytomegalo, rejection, either acute or hyperacute or chronic, and the recurrence of original disease. Always put them with the graft complication. Immunosuppressant medication already mentioned in the discussion. So steroid and cause Cushing, hyperglycemia, hypertension, or the weight gain or osteoporosis, whatever the manifestation or the complication of steroid. And for the tacrolimus, tremors, hyperglycemia as well, lipid disturbance. For the cyclosporin, hyperkalemia, hypertrichosis, or hypertension as well, gum hypertrophy. Okay, these are the common side effects for each medication they are asking. Then the investigation, you can mention everything, but don't forget the specific investigation here, drug level, either cyclosporin or tacrolimus. Okay, they are screening for them. The management plan according to the presentation of the patient, either pain or jaundice. So you have to speak about the treatment of the manifestation. If he has tummy pain, so you have to know the cause of his abdominal pain. If he is presenting with jaundice, you have to know and to screen why this patient is jaundiced. It might be drug, or it might be obstruction of the bile ducts, or might be infection. So you have to talk about the possibility and how to treat according to the cause. So treat the underlying cause. I try to make it concise as much as I can. Now we will open the discussion. Anyone has question, comment, suggestion, please raise it.
Dr. Bazim,
Yeah.
sorry.
Yes, Dr.
When she was asked about the differential diagnosis,
Off.
of the scar,
Yes,
the
yeah,
Mercedes
the good
Benz sign.
question. Yes.
Yeah.
Yeah,
I don't know.
good
Is
question.
that, I don't know if I'm to answer that question, because she was correct though, because she was mentioning some surgical intervention. But I don't, is it also nice for us to talk about the differential cause of for instance, of the likely liver transplant, instead of talking about differential cause of the scar itself? I don't know. I need some
No,
correction.
yeah, I will correct you. According to the examiner question, you can
Yeah.
ask him,
Yeah.
sir, what you mean by differential? Do you need differential of the scar or differential for the hepatomegaly, for example, or chronic
Okay.
liver disease? This is the first issue. Be ready to be asked about the differential of a scar.
Okay.
So you can talk on the top of them. Don't mention any surgery apart from or after mentioning the transplant on the top. So don't tell the examiner, yes, cholecystectomy might be the indication of this surgery or this scar. Okay, yeah, it might be there, but it's not common to be done. Possibly liver transplant in the top. You can talk about hepatectomy or maybe hepatic abscess or liver abscess, but I don't think cholecystectomy will be with this large scar. Okay. But also to be clear, ask the examiner what exactly you want me to mention, either differential for the scar or differential for the chronic liver disease, or what the cause of the transplant itself. He might ask about the differential of transplant, so you can talk about what we mentioned earlier, right?
Okay.
Okay. Any other question? There's some comments. I will try to read quickly. Anyone also had comment? Please raise it. BBC or primary biliary cirrhosis, primary cholangitis or primary biliary cholangitis, and paracetamol toxicity. Please, if you will, the one commented this one. If you want to comment about the indication, don't put the autoimmune or the primary biliary as on the top. Try to make it as I made earlier, as a systematic. So autoimmune, then you can enumerate the cause of autoimmune liver disease. Don't mention primary biliary as the top indication of the transplant. because it's not very common or even not common. There is another common disease, as I said earlier, according to the age group. So you can talk about according to the age group. Vitamin C deficiency, yes, for the gamma hypertrophy, phenytoin, chronic myeloid leukemia. Good to know and good to comment. But particularly in this patient, you have to mention the cyclosporin. Other causes, yes, you can say these causes. In abdominal examination, Dr. Sarah Ibrahim, in abdominal examination, it's better to do auscultation after inspection before palpation and percussion, as those may change the bowel sound frequently. No, doctor, I am not agree about this. Do this examination steps as you are doing in the chest and the cardiac. So we are starting by inspection, palpation, percussion, auscultation. Bowel sound is not important, and you will not have change of the bowel sound or, for example, absent bowel sound unless the patient is present, for example, with intestinal obstruction. Okay, it's not common in cases, I mean. So to pick up a finding of absent bowel sound, it's not common in cases. It's something maybe acute or hyperacute presentation. So a patient will present with abdominal pain, severe abdominal pain. But in cases wise, I mean, it won't be there. So whatever you are trying to auscultate, it will not be positive. But if you palpate, you will have a lot of finding, hepatomegaly or splenomegaly or ascites or palatable kidneys. Splenomegaly, yes, again, is the pictures. Okay, secondary hemochromatosis, exactly. Hepatitis, hemochromatosis, defoxamine, Dr. Abd Al-Huda, thank you. Chipmunks, Dr. Imaka, I think he mean the oral form of chelating, right? Yes, hemolysis is very important to talk about as a complication of thalassemia or sickle cell. It's very common presentation. They might have, due to stress or infection, they might present with severe hemolytic anemia. Yes, if splenomegaly, Dr. Ibrahim. Ashur, first is hereditary spherocytosis. In sickle cell as autosplenectomy due to recurrent vaso-occlusive attacks of splenic vessels and repeated infarction. Perfect. Dr. Imaka again, Dr. Emika, CBC, microcytic anemia, peripheral smear target cells, nucleated red cells, retic count elevated due to increased red cell production, serum bilirubin elevated, indirect bilirubin from hemolysis. Iron studies assess for iron overload, hemoglobin electrophoresis. By the way, hemolysis workup, total hemolysis workup, liver function, total bilirubin, direct bilirubin, LDH. You have to mention all these things. And of course, the liver function test, albumin, AST, ALT, and gamma GGT, alkaline phosphatase. Okay, so all to be mentioned. Dr. Mariam, deferoxyrox, deferbron. Yes, this is the one as oral, deferbron. Thank you, Dr. Sarah. Deferbron. Thank you, Dr. Maria and Dr. Al-Huda. Okay. I think we are done with the comment. Anyone has verbal comment, please feel free to comment. Dr. Ayula, you want to add any comment? Dr. Sarah as well. Anyone with any comment?
No, Doctor. Thank you.
Okay, I like whenever you are writing your comment, you can repeat again the comment verbally. It's free, it's open to discuss, not only to write. Whenever you are talking, you are gaining a lot of confidence. So you know how to talk with the examiner. You have the confidence to talk with the examiner. You will not write in the chat or you are not chatting with the examiner. You are talking and answering verbally. So whenever you are talking, you are gaining a lot of confidence. Anyone has comment, feel free to comment. And if no comment, we can end the session. Please, anyone has comment, suggestion, any question? Is it clear for all? Satisfied about the topic?
Yes.
Oh, okay. Thank you, Dr. Ayula. We'll come back to the session.
Oh, thank
You
you.
have been absent for a lot of sessions. Anyway, you're always bringing nice cases. So we are waiting for you. And everyone is welcome to attend and to practice. Thank you, everyone. Sounds no question. Yes, thank you, Dr. Nahla. Okay, see you tomorrow, inshallah, with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Good night.
Thank
Thank you so much.
Thank you.